All right, as we continue forward in this video, we are going to review CPT and ICD-10 guidelines and tips for the 80,000 series pathology and laboratory, as well as CPT coding, ICD-10 coding tips for anesthesia coding. So when physicians are performing simple labs in their office, they do it under CLIA, and CLIA stands for the Clinical Laboratory Improvement Amendment. CLIA regulations establish standards for laboratory testing. Physicians can apply for a CLIA waiver, which is issued by CMS. The CLIA waiver allows physicians to run approximately 80 tests in office that have little risk of error. The list specifies test kits by specified manufacturers that are easily run in a physician's practice. Laboratory services that are performed under CLIA waiver should be billed with a QW modifier. A lot of offices now, Medicare providers, they actually do not draw blood in the office anymore. So if a patient has Medicare, and even other insurances, a lot of times they're being sent now to a freestanding laboratory facility. And so that CLIA waiver is no longer something that physicians are generally using in their office. You still may see blood being drawn like in oncologist office or more specialty offices, but for general practices, we generally don't see them drawing blood in the office anymore. When there is a suspicion that the lab test will not be covered by Medicare as a result of frequency, diagnosis, or even equipment treatment, patients must be informed prior to the test being performed that they may be responsible for payment, and they must be given the option to have the test or not. The Medicare Advanced Beneficiary Notice, or ABN, must be presented at that time to the patient, and the patient must sign indicating, yes, they're going to go ahead. They understand that the test may not be covered and that they would accept responsibility for payment, or they would mark no, that they don't agree to that, and then they would choose to not have the testing done. Medicare will only accept their form CMS R131, which may not be altered in any way. So, and if it's a test that requires an ABN and the physician's office fails, there's actually a modifier for the ABN that you would place on the claim form to show that the patient signed the ABN. If the office failed to have that patient sign the ABN when it was required and the service got denied, the provider's office cannot bill the patient because they did not properly have them sign the advanced beneficiary notice, letting them know that it may not be covered. So when that happens, you cannot bill the patient. The provider has to write it off, or that means they basically did the testing for free and they're not going to be reimbursed for it. So it's important that if the office is drawing blood and it's a Medicare patient, to understand whether or not you're going to need that advanced beneficiary notice. And it's everybody's responsibility to make sure that it gets signed. So some other modifiers that we see in laboratory testing is B90, reference or outside laboratory, billed by the physician but being performed by an outside lab. 91, repeat clinical diagnostic lab test. This can be done on the same test, but not in the same day. You would not use a modifier 91 if it does due to an error, and it is not used if there's a better code for a series of tests. 92 is for alternative laboratory platform testing. This is for portable test kits, such as a single-use disposable chamber. And then 99 is our multiple modifier. So if you're going to have more than 4 modifiers for one particular CPT line, you would use 99 to indicate that there are multiple modifiers for this particular service. For your organ and disease-oriented panel, these group a test of commonly ordered blood tests or panels together. All tests in the panel must be performed in order to use that particular CPT code. If all tests are not included in that particular panel, you do not want to change that CPT code. You want to find you're either going to code each one of those blood tests separately or see if there's a panel that include just those specific tests. The Path and Lab section begins with organ and disease-oriented panel. With each panel code, there's going to be a list of tests that is included in each panel. All the tests in it, and again, in that panel must be performed to be able to bill that panel code. If even one test is not performed, all tests must be individually billed. If all the tests in the panel are performed with additional tests as well, the panel can be billed with the additional services. So you want to be looking for the words and, for or the word and. Laboratory coding can be a little confusing, especially with the panel, until you understand that process or that concept about the panel has to include all of those tests in order to choose that particular code. So what does qualitative mean? It means what is present, and quantitative is how much is present. So qualitative defines whether there is a drug present in the specimen. Quantitative identifies how much is in the sample. So for example, a blood sample may show alcohol, qualitative. A blood alcohol level is quantitative. A qualitative study does not have to precede a quantitative study, and chromatography is another method for determining substances in a sample. So like when they do a urine test to check for drugs, that's going to be qualitative. If they were to do a blood panel to determine how much of a particular, such as THC, is in the blood, they could do a blood test to determine how much. And then presumptive drug class screening. These are used to identify the use or non-use of a specific drug, but not the definitive presence of drug or drug metabolizes in a sample or specimen. There are detailed guidelines for presumptive drug class screening and the 3 different methods for testing. So definitive drug testing is going to look at the qualitative and then the quantitative. So qualitative, positive, negative, present or absent. And then quantitative, the amount or the quantity present. There is a definitive drug class listing that shows the different drugs and the class under which the drug should be billed. Quantitative tests for drugs are given for therapeutic purposes, such as for patients that are on prescribed medications, such as something that can have a long-term effect, say on their liver. The drug tested are those that may become toxic or too low for the patient to have a therapeutic benefit. The specimen may be blood, serum, plasma, or cerebral spinal fluid. Even patients that are on long-term, like seizure medications, they're going to have therapeutic drug assays done just to check the levels and make sure that they're maintaining that therapeutic level, or blood thinners as well. So they know if they need to adjust anything like that. Vocative suppression testing. This is going to where the physician takes baseline lab tests and then administers medication either to evoke a response or attempt to suppress one. Subsequent lab tests are taken to measure the effectiveness of those agents. The number next to the lab test is the number of times that the test is performed to complete this test. The drugs or supplies administered are reported separately. Drugs are typically administered via IV, and the infusion codes are also reported and are found in the medicine section. So if there was a physician in attendance, we would want to make sure we're using those prolonged care codes. And your prolonged infusion codes come from the medicine section. Surgical pathology. So this is when a specimen or tissue sample has been submitted for a separate examination and a pathological diagnosis. Each specimen that is to be evaluated has to be identified separately. These codes are identified in 2 levels, levels 1 through level 6, and each level contains a different level of specimen or level of diseased tissue. Level 1, a level 1 exam is a visual exam only during which the pathologist just identifies the specimen. When you move into the next levels 2 through 6, the physician is doing not just a gross exam, but they're also looking at the tissue, the blood, the cells, and other specimens, whatever has been sent under the microscope. And then you're also going to have the use of additional codes for special types of stains. Surgical pathology. We want to take care with surgical pathology to identify the specimen as well as the reason for the specimen or surgery, such as a prolapsed uterus, hysterectomy, neoplasm. So levels of surgical pathology will give specific examples of tissue being inspected, and the reason. So we see here 88305, a level 4, uterus with or without tubes and ovaries for a prolapse. Whereas an 88307 is a level 5 for uterus with or without tubes and ovaries other than neoplastic or prolapse. For this code would be used for something other than a neoplasm or a prolapsed uterus. And then 88309, level 6, uterus with or without tubes and ovaries, neoplastic. So this means that it is cancerous. So it's going to be specific. And then consultations under pathology, we have 4 types. The first 3 are similar to consultations that like we see under E&M. The pathologist receives prepared slides, tissues from which he makes his own slides, or tissue to make his own slides along with the patient's medical records. The consultation guidelines still must be met, such as a request for the consult, render an opinion, report back to the requesting provider. The last type of consultations are for consultations during surgery. So specimens are taken during surgery and sent to pathology, where the pathologist then takes the frozen section and block to view under the microscope. And sometimes they will even wait to move on in the surgery while they are waiting for the results from that pathology report. So question 18 in our pretest, Mr. Smith is having a physical. His provider ordered the following serum blood test: CBC automated, CMP or comprehensive metabolic panel, and a thyroid stimulating hormone TSH assay. So our correct answer would have been A, 80050 and Z00.00 for our diagnosis code. So in reviewing our guidelines, we go in 80050 general health panel. This panel must include the following: a comprehensive metabolic profile or panel, a CBC automated or automated differential white blood count, or the blood count complete CBC automated and appropriate manual differential white blood count, and a TSH. And so we know the patient had all 3 of these done. So an 80050 general health panel would meet that criteria. And then a Z00.00 is our diagnosis code for an examination, a routine examination. And that concludes our 70 or an 60 or pathology and lab. And now we will move into anesthesia. I lost my train of thought there for a second. All right. So with anesthesia, anesthesia is not just used for putting the patient under so they can undergo a procedure. There are actually 4 different types of anesthesia. Local anesthesia is used for minor surgeries. For local anesthesia, the services are going to be included in the surgical procedure, and they're not going to be billed separately. They are MAC stands for monitored anesthesia care. The patient has decreased awareness, but will respond to stimuli. So they may be able to answer questions. The patient is not unconscious, but they will have no memory of the procedure. They are able to control their own airway, so they don't have to be put on any type of oxygen. Regional anesthesia is going to include blocks, spinals, and epidurals. And then general anesthesia is when the patient is fully unconscious, they are unable to control their own airway and rely on the anesthesiologist to breathe for them. The regional type of anesthesia is a lot of times is used for pain control as well. So some anesthesia terminology that we will see in the CPT section that we need to understand. One lung ventilation, or OLV, is one lung is deflated to allow the surgeon greater room to work in the thoracic cavity. A pump oxygenator, this is the same thing as putting the patient on a bypass during cardiopulmonary surgery. So they're on the cardiopulmonary bypass. And then intraperitoneal and extraperitoneal identify the locations within or behind the peritoneal cavity where the organs lie. So in our intraperitoneal, this is within the peritoneum. This is going to include the upper abdomen, and the organs that we find in there is going to be the stomach, liver, gallbladder, spleen, jejunum, ascending and transverse colon. And then the lower abdomen is going to include the appendix, the cecum, the ileum, and sigmoid colon. So you can see here it's including the stomach, liver, gallbladder, small intestines, large intestines, spleen, and the appendix. And then for the extraperitoneal or retroperitoneals, this is the space in the abdominal cavity behind or outside the peritoneal cavity. This in the upper abdomen area, this is going to include kidneys and the adrenal glands, as well as the lower esophagus. In the lower abdomen, this includes the ureter and urinary tract. And then other is going to include other or aorta and the inferior vena cava. So organs found in the intraperitoneal and extraperitoneal cavities are differentiated by upper abdomen and lower abdomen. If the patient has an appendectomy done, the anesthesia code will come from the set of codes for the intraperitoneal or lower abdomen. When it comes to our anesthesia fees and how it is calculated, it is calculated by adding the anesthesia base units, which is similar to an RVU, but for anesthesia services. So it's going to be base units plus the time units. Time units are calculated in 15-minute increments, unless the payer contract states differently. Modifying factors, additional units. These are added for carriers other than Medicare. Modifying factors include additional units from the physician's physical status modifiers or qualifying circumstances, add-on codes to be discussed here in just a few moments. So then we total all of the above and multiply the units by the anesthesia conversion factor, which totals the anesthesia fee. So base time plus time units plus modifying factors equal our total anesthesia units, and our total anesthesia units times the conversion factor equals the anesthesia fee, and that's going to include geographical location and all of that. All right, so time begins when the anesthesiologist begins to prepare the patient for anesthesia. This is going to either be in the OR or in an equivalent area, and ends when the patient is safely under post-op supervision. So per the guideline, it begins when the anesthesiologist begins to prepare the patient and ends when they are in post-op. Anesthesia time usually is calculated in 15-minute increments, although coders should be aware of the specific payer contracts. So for 15 minutes, it would be 1 unit. For 60 minutes, it would be 4 units. So you want to place a chart in your book to help you calculate the time in 15-minute increments. Physical status modifiers are assigned by your anesthesia provider. The coder needs to look for a diagnosis to report it, and then documented in the anesthesia. It's documented in the anesthesia record. So Medicare does not accept the physical status modifier. So if it's a Medicare patient, you would not include this physical status modifier. They are assigned by the anesthesiologist when they examine the patient. It indicates the patient's overall health prior to surgery. The modifier or assessment of the patient's health will be documented in the patient's medical record. There are 6 physical status modifiers from P1 through P6. The patient will be assigned 1 P modifier, which will be reported on the claim along with the anesthesia code. In addition, modifiers P3 through P5 carry extra weight or extra units, which are included as additional qualifying factors for all carriers except Medicare. So because that patient's risk is higher, the anesthesiologist is actually going to get paid at a higher rate because of that increased complexity or risk to the patient because of their health status. And then qualifying circumstances. There are 4 of these in which additional information about a unique anesthesia service. The care must be taken with these codes as they are not billable with every anesthesia code. They are listed in parenthetical statements below the anesthesia codes. So qualifying circumstance 99100 is for a patient under 1 or over the age of 70. 99116 is anesthesia complicated by hypothermia. And you can see these are all add-on codes. So these are child codes, not parent codes. 99135 is anesthesia complicated by controlled hypotension. And then 99140, anesthesia complicated by an emergency. So for whatever reason, there's some type of an emergency and they have to perform surgery. It's a matter of life and death. That would be that type of qualifying circumstance. But again, we want to make sure that the payer accepts these qualifying circumstances, like such as Medicare. They do not. And then we have our HCPCS modifiers for our anesthesia. So there's our anesthesiologist modifier indicating who is performing the anesthesia. Is it being performed by the anesthesiologist? Is the anesthesiologist supervising 4 concurrent procedures? Medical direction of 2 to 4 concurrent procedures, even the medical direction of 1 CRNA. And then we have our CRNA modifiers, and then our MAC or monitored anesthesia care. And then under multiple surgeries, only one anesthesia code is going to be selected. The exception to this rule, of course, would be any anesthesia add-on code, such as 01968, and the anesthesia for cesarean delivery following neuraxial labor analgesia anesthesia. So they provided anesthesia during a vaginal delivery and for whatever reasons, mom now has to go be delivered by C-section. And so then that would be a new anesthesia code. So that would be the exception to that rule. In the anesthesia fee calculation, the total time for all procedures is going to be used. So you want to report to the most extensive or most complex procedure to assign that anesthesia code to if there are multiple procedures being done and it has nothing to do with anesthesia for a cesarean delivery. Some other modifiers, 53, it's going to be for a discontinued modifier or procedure. This is used if the surgeon discontinues the procedure for whatever reason. 59, distinct procedural service. An example, general anesthesia during surgery, then an epidural is placed for post-operative pain management. So they would want to get paid for that extra procedure. So they would add that modifier of 59, indicating these are 2 completely separate procedures that were performed during this time. And then additional anesthesia modifiers, 23 for unusual anesthesia. This can be when they use anesthesia in a situation they normally would not, perhaps because of an agitated patient. 53 discontinued procedure, 73 discontinued procedure prior to anesthesia administration, and 74 discontinued after anesthesia administration. All right. Question 19 in our pre-test. A 4-year-old healthy patient presents for tonsillectomy and adenoidectomy. What is reported for the anesthesiologist? So this would be C 00170 with modifiers AA and P1. So the anesthesiologist is performing the anesthesia and P1 indicates a healthy patient. So as we see here, and then we would not use any add-on code because there's no qualifying circumstance here. And that concludes for anesthesia and for pathology and lab.